Welcome to everybody. My name is Dr. Charu Singh. My background is in anesthesiology, critical care, and for the last approximately 18 years, I have grown into palliative medicine. And my co-facilitator is Dr. Roop Kursahani. You have heard his talk yesterday. So for those who are joining us for the first time, let me tell you, he's a very reputed neurologist working in Hinduja Hospital. So I'm honored to co-facilitate the session with Dr. Roop. I'll hand over to Dr. Roop to do a quick recap of yesterday's session before we go on to distress at today's session. Dr. Roop.
Thank you. I'm audible, I guess.
Yes, yes.
Thank you, Dr. Charu, for introducing me. And I'd like to begin by telling you that we have followed Ramesh through his journey from the time that he develops COVID. We see him as he is a person with comorbidities, and we talk to his family. We manage his symptoms. And yesterday, we came to the last stage of this journey in which he actually passes away. And this passing away, because we have been able to use good symptom control, is something that we were prepared for. And the family also was prepared for it because, in a sense, rather than the having to withdraw him from the ventilator, the decision that was made with everybody's concurrence was to withhold taking him to the ICU or even putting him on the ventilator and to keep him comfortable. But in palliative care, that is not the end of the story. And we also have the task of addressing distress. That, of course, that Ramesh has passed, but there is a lot of other distress that is part of what we do. And unless we accept it and address it, we will always be floundering. So today, can I hand it back to Dr. Charu?
Yes, sure. Let me begin sharing my screen. Is this visible?
Yes.
I am audible?
Yes, perfectly.
Okay, thank you. So I'd like to thank Dr. Roop for very quickly summarizing Ramesh's journey from his diagnosis of COVID to his passing away yesterday. I'd like to thank Dr. Chitra Venkateswaran, who's a good friend of mine and a psychiatrist, who has kindly allowed us to use this material that has been prepared by a group of palliative care physicians from Kerala called PalliCovid Kerala, as you can see at the bottom of your screen. So what is distress is something that we need to think about. And when a patient is ill, who all are the people who can have this sense of distress? I was just, before coming online, I was looking at other synonyms for the word distress. And Google, as usual, my go-to, said it could be anguish, suffering, it could be pain, agony, ache, or affliction. So whatever the word distress means to you. But it is, the word distress is actually a word which encompasses a spectrum of conditions. Before we go on to the actual distress of Ramesh, his family, and other people involved in the care of Ramesh, let's quickly go through the learning objectives. Our idea is to understand what all issues can come up emotionally and mentally for the people involved in Ramesh and people around him and the larger circle around him. And to focus on how to identify distress, how to take care of ourselves, and look at certain complex terms which we have not as yet ever encountered. I had not till about 2 or 3 years back. So that is just an introduction for you today. So going back to Ramesh, I'm going right back to while Ramesh was alive. We know that he was 70 plus, he was bedridden with stroke, and he had multiple comorbidities. And he has been hearing through the television about how many cases are going up and who is going to get treatment, who's going to get a bed. And Ramesh could have had a lot of distress. I'm using that word here, but his distress would have been perhaps the fear. What if I catch uh, uh, this Wuhan virus, as it is now currently known? How if I catch it? Anxiety. Will I recover? Will I die from it? Will I become a burden on my family? Will I become separated from them if I catch this Wuhan virus? So these are some of his concerns which can cause emotional distress for Ramesh. What do you think could be the distress that Ramesh's family would have been going through? And as healthcare providers, we also get involved very closely with our patients, and some of the distress is also transferred onto us. So I would like to hear for you all to put in the chat box the things that you fear, or the things that you understand as distress to be. What would Ramesh would have been feeling at that point? What his family would have been feeling through the journey and at the end? And what about the healthcare providers?
Okay, so Dr. Charu, I asked them. From the Hindi side, I offered the word for distress. I said pidha is one word.
Yes.
So there have been suggestions for words from, there's the Filipino Pagbalisa, in Indonesian Menderita. I'm waiting for the Bangla version and the other version. So to name the emotion, distress.
Well,
Let's go on.
I didn't know we had international participants today. So, yeah, warm welcome to the virtual India, as can happen in these COVID times. And hopefully you'll be able to visit us one day.
From Bangla, it's Kashto.
Kashto.
Yeah, I can understand that.
I can relate to that.
Yeah.
Yes, and what would the staff members also be feeling? That is also something that we need to think of. I remember one of the sons of Ramesh, who had come from abroad, was also suffering from guilt. Was he the one responsible to transfer the Wuhan virus to his father and resulting in Ramesh getting COVID-19? So that feeling or emotion is also a part of distress. So these are some emotions that we all go through in our normal lives based on the situation that we are facing. And these feelings or concerns come and go. But in certain situations, they can become pervasive, and they can actually lead on to psychiatric conditions like clinical anxiety, which is not just being anxious, but would require medication, clinical depression, perhaps grief, trauma. These are some of the words, these are some of the psychiatric aspects of distress that can come in. And it is very likely that the family of Ramesh would be feeling through this, because they're sitting outside helpless, watching, not being able to see him, not being able to reassure themselves or Ramesh that things may be okay, may not be okay, but he may not suffer. So who are the people who are highly likely to develop distress? So those people who are quarantined and isolated, they don't have anyone to talk to. There might be a nurse, but because of the rostering of nursing staff and doctors, and so the nurses may not be looking after just 12 patients. They may be looking after more than that, and they may not be able to relieve someone's concern if they are in quarantine or isolation. So communication for them is difficult, and they are very likely to be in distress, perhaps purely because of loneliness also, which also falls under my definition of distress. So people who have contracted the disease, we still don't have any treatment for this COVID-19. And last night I saw the TV and it said it will only be by mid 2021 that a vaccine is going to come out. Till then, all we can do is support a person, support the physical body, and hope that the person's body is able to generate enough antibodies to fight this virus. So, and of course, periodically over the months, the pathophysiology of the disease has changed and the treatment also has changed. Once it was, everybody was talking about ventilators, and I don't hear the word ventilator at all. And I keep hearing about plasma, Dexona, hydroxychloroquine, but there is not enough evidence. So those people will also, their level of distress would be higher. Vulnerable population, my elderly people, anyone above 65, at least in Italy, anyone over 65 with any comorbidities were considered to be at high risk, and because of lack of healthcare facilities, shortage, that's a developed country, the shortage, they also ran into a shortage of facilities and were not able to provide treatment or a bed or a ICU bed to these people. So they would be more anxious. My parents are plus and minus 80. They're in that range. They haven't stepped out of the house for 4 months. They are perhaps a little less concerned, but as their daughter, knowing all that can go wrong, I'm more scared than they are. So also people who are at risk, there are some people who have had a loss in their family. They have lost someone recently and they are still grieving for them. And that loss may not have been because of COVID-19. It could have been a road traffic accident. It could have been a chronic illness by which they would have lost a loved one. So when one of their family members is diagnosed to have COVID-19, they are likely to be at a higher risk of going into these complex range of distress, just from anxiety to the psychiatric aspect. And yes, healthcare workers and carers, we've seen enough interviews on the TV where conversations have been had by nurses and doctors, and everybody's turning up for work and they're all saying that we are very scared that when we go home, we will take the virus back with us and we'll affect someone in the family. And just because someone is not 65 does not mean that they cannot acquire COVID-19 or they might not lose their life because they're not 65. We have seen that people who are lesser than 40 have also lost their lives. So for healthcare workers and carers also, the risk of distress is very high. Dr. Rup, any inputs in the chat box about what else?
Yeah, their main concern is about healthcare workers. I mean, the kind of distress that healthcare workers would go through because of feeling sad, failure, guilt,
Yes.
lack of interest in the work itself, confused, lack of confidence, fatigue. These all emotions that healthcare workers, and I think it's important for us to acknowledge that
Yes, absolutely.
we won't be healers unless we are healed ourselves.
Absolutely. And that word fatigue really jumped at me when Dr. Ru mentioned it, because yes, we have mental fatigue and we also have physical fatigue. Again, I will go back to the rostering. To save on PPEs, nurses are being asked to do longer shifts. And longer shifts mean longer exposure. And who do I have to do what for? And how do I have to communicate to the doctor? At the same time, I have to pass on the message to the family. And this can cause a lot of confusion, fatigue, irritation, for the healthcare workers. And we are going to focus on healthcare workers later on in the presentation. So this is a little complicated slide, and I'm going to take a few seconds or a couple of minutes to explain this to you. This is more relevant for Ramesh's family and the healthcare providers. Ramesh, once he developed COVID-19 because of his comorbidities, he wouldn't have had much time to live. I have not looked after COVID-19 patients, but I'm told that the deterioration happens in 48 to 72 hours. But for the rest of us, it is a spectrum. We go from health to reacting, to being injured, to being ill. That's the path that a person who goes through distress. And what are the aspects in which this would reflect? If you can see on the left-hand side, you have right on the top, mood fluctuations. So emotions are involved. Your sense of humor, performing well, being controlled mentally. So those could be cognitive functions. Your daily activities like sleep, eating, doing your normal daily activity, that varies. And I'm just going to go to the bottom, how people cope. Someone who's healthy and is going through a phase of distress will look at positive things to cope with. They might start going for a jog or a run or exercise to burn out that distress, that negative energy that they feel in their body. But if they're reacting, they might not be very regular with a disciplined lifestyle, but may fall into unhealthy types of coping. And as they go from injured to being really ill, this coping mechanism will also deteriorate, and they might end up with multiple addictions, not just gambling or alcohol. They can be multiple addictions for them. So, so I think it is. Is there any question or doubt about this slide? That this is more relevant for people, for the family of people of COVID-19 patients and healthcare workers also. So we have to be aware of this thing. Perhaps you can take a printout of this and stick it up in your isolation ward so that you know where you fall under. Are you sleeping properly? Are you having nightmares? Or do you want to sleep all the time because all that fear, all that mental noise, you want to shut it out and block it? Then you're ill and you need some support. Either you need to talk to a specialist, talk to somebody, or go see a psychologist or a psychiatrist. So this is something we need to remember is relevant for the family and for the healthcare workers. Now, we do know since we spoke about the definition of distress and what distress means to all of you, we know that we feel distress in our psyche. Dr. Roop is the neurologist here, so brain, mind. Where do we feel it, Dr. Roop? Psychological distress. In Hindi, I think they say man, dil,
Yes.
dimag, but perhaps I think all aspects do get involved, just as you've seen in the previous slide. What about all of you? Where do you think people feel or what are the manifestations of psychological distress? Where is psychological distress manifested in the body? You can take some hints from the previous slide.
Yeah.
I hope some answers are coming up in the chat box.
Not yet, but I think they have got that bit about healthcare workers and the manifestations that come up there. So I think we should accept that we are no different from our patients and their families, and what we think of affects us, affects them as.
Absolutely.
Mm.
So this is an interpretation of the previous slide, that the psychological distress may manifest as emotions, feeling stressed all the time, feeling anxious all the time, negative thoughts coming in about yourself, about your family members, feeling sad, low mood. It can be physical. Distress can manifest in the physical domain, where you're restless, you can't sit, you want to move all the time because you want to burn out that energy, or you may feel aches and pains in your body. Many of us, when we have an exhausting day, we feel an ache here in the neck and the shoulders from sitting in front of the computer all day and conversing with a lot of people. So acidity, yeah, so this distress can be felt in the stomach also, and in behavior, our eating and sleeping patterns. But what I want to point out, most important for all of you, is that we need to keep an eye on what are the pre-existing symptoms of the patient's family. Now, I'm going to stop talking about Ramesh because we've already lost him. And this distress that we're talking about is more relevant for Ramesh's family and the healthcare providers. So even for healthcare providers, we need to see what is our mental state. Am I generally an anxious person? And now being in this environment, my anxiety is pervasive and is destroying my ability to have a good restorative sleep? Or is my blood pressure shooting up? Is my blood sugar more difficult to control because sometimes I don't feel like eating at all, but I'm supposed to take my oral hypoglycemic agent? So whether it is for the staff or for the family, we need to keep an eye on the pre-existing symptoms and see, or pre-existing conditions, it should be, and see whether they are getting worse, including substance abuse. And there are a couple of red flags. Now, we all cannot become psychologists or psychiatrists, but there is a little bit of everything that we are taught through our MBBS and MD, and as we work and interact with our professional colleagues, we learn more things. So there are certain things, a person who's very agitated all the time, is disoriented, is going into severe substance abuse, or is having hallucinations, or is thinking of suicide. These are people who we should be able to identify and refer to a psychologist or a psychiatrist. This is a little out of context of COVID-19, but I lost my cousin at the age of 35 to a myocardial infarction. And his younger brother, who was perhaps 32 or 33 at that time, his first response was, let's all take something poisonous, and the rest of the family, let's all of us die together. That was his first response. Which kind of scared everybody, because while others may not agree with him, what if he ends up doing it by himself? So that is something that we need to keep an eye out for. So when we're talking about distress, we also need to be able to estimate when should we intervene in someone's distress, or when a person's own coping capability will kick in. So on the left, you can see there is a distress thermometer, which starts from 0, which is no distress at all, very happy, comfortable life. And 10 out of 10 is extreme distress. There are people sometimes who may say that I'm feeling distress, which is 20 out of 10. And you may think that's illogical. But yes, the distress is that significant. And any distress beyond 4 needs a specialist opinion. So we need to either refer them to medical social workers, psychologists, or psychiatrists, depending on who you have available in your setup, in your working area. It may not be the same in every place. Another thing that I would like you to note is on the right side, there are reasons given for distress. Things like practical problems. When I have to get admitted to the hospital, who's going to look after my child? I haven't, now in the COVID-19 scenario, lots of people have lost their jobs. So how am I going to pay my EMIs now for the next 6 months or something? Family problems. If I'm going to end up dying, who's going to get my daughter married off? There may be emotional problems. So distress is not directly related to, distress is not only emotional problems, but distress can be because of physical problems. As you can see, the biggest list is of physical problems: uncontrolled pain, not getting sleep. All this can be very distressing, and these are things that we can intervene in and correct, the physical things. There are certain things like spiritual and religious concerns. I'm going to address this a little later in the presentation. So this is another tool, the nurse protocol. So one is the distress thermometer to understand how much is the distress. If it's less than 4, possibly the person would be able to cope on their own, recover on their own. If not, they need help. We need to guide them to the right person. But sometimes it's also useful for us to explore whether there are some people who express their distress and there are some people who bottle it up inside them. So a person may be very angry. Just recently, another family member was in the hospital and the son got very angry that the doctors are not coming and we are waiting the whole day for the doctor to come and visit. That gentleman's mother was 79 years old. So he was very angry. So sometimes it's good to say, I can see that you're angry. Can we sit down and talk about it? We need to understand the emotion. We can empathize with them by saying, I can imagine that this must be extremely stressful for you. Or you can say, I can't even begin to imagine what you're going through because I am not in your shoes. So I cannot even imagine what your stress may be. We need to respect the patient and caregiver and their feelings. Everyone is entitled, everyone is different. Our 5 fingers have different sizes and different functions, and all of them are important when we need them. So we need to respect the patient and caregiver and not look down upon them for certain things. We need to support the patient or help them find sources of support within themselves. We can ask them, when you've had a difficult situation in your life before, what has helped you? Has prayer, doing prayers help you? Meditating help you? Is there a friend or a family member to whom you can talk, ventilate? I use this analogy very often because it's applicable to me, that when I'm on the gas stove and the pressure cooker, the pressure inside builds up, and when the whistle goes off, a little bit of steam goes out, then the pressure cooker can sit on the fire for a little long period. So so I tend to ventilate and relieve my distress and then go on with my task at hand. So that is my way of coping. But our way of coping may not be the coping for the way to cope for Ramesh's family or the healthcare workers. So we need to help them to find out what has helped them in the past. And the most important thing is, like I mentioned about the gentleman and his being angry that the doctor has not turned up. There can be another emotion behind the emotion that is being expressed. It was his fear. His mother is 79. She's running a high temperature. She's got hypertension. She's got diabetes. It's been 29 days in the hospital. Has she acquired COVID, or is it the orthopedic surgery that she had and she's acquired an infection through that? So there is a fear which is being expressed as anger. So we need to go and look at what is the concern or what is the emotion behind the expressed emotion. Is that clear? People can relate to what you're talking about?
Yes, I think they haven't reacted to, but I guess one thing that comes through with the nurse protocol is that you need to name the emotion. If they are
Yes.
obviously angry, you say, yes, I see you are angry. You're actually respecting that emotion by naming it. So you must actually start by doing that. But uh, this is part of it. Part of it also is for every one of us to figure out how, and that's what people on the chat have been doing, is how do they handle distress themselves.
Yes. Yeah, so that's very important. I think we should perhaps use this for ourselves too. To understand that my irritability is actually coming from a place of anxiety. So it's important, like naming the emotion is important because that's what everyone is seeing. So we go back to the healthcare providers. So one of the doctors in the team has been asked to vacate and his neighbor shoos him away when he drops in at the flat. This has been happening. There was a doctor who finished his duty in the hospital and he was staying in a housing society, and the society people said, stay out, you're bringing the virus with you. You're not allowed to come back into the house, into your own house. And this is, I would say, is not restricted only to people who do not have adequate information. Because I am seeing this kind of behavior in my area where there are IT professionals who are staying in my housing society, a gated society. So there are IT professionals and they can get information through, not through Google, but through better sources of information, perhaps Google Scholar. They can get information or they can ask for information. Our government has put out multiple guidelines. They've put up Arogya Setu, which gives you the correct information. So rather than watching the television, and I'm going to use Dr. Roop's terminology, which I like very much, the University of WhatsApp. It's a very dangerous thing. So I have seen it in my society that there was a family, 4 of them went for a wedding and 3 came back COVID positive and there was 1 in quarantine. So I am on the WhatsApp group of that society. So I offered to the family that if you require something, if you want us to get groceries, medicines or cooked food, I'm happy to provide it to you. There are your neighbors are there. They will be supportive, but we are also there. And I got a very angry message with lots of exclamation marks and question marks saying that the 4th person is also under quarantine. And it irritated me, but I had to, this thing is not about me. So I wanted to tell them, see, if the lady who's cooking the food is unwell and cannot cook, how much are 4 people going to eat? I can make some rice and I can make some curry and can leave it outside the door. And I don't even have to come in contact anywhere near the COVID positive patient, but we can support them, and it's only a matter of 2 weeks or something like that. And I put my phone number there, so this is not just an empty offer. And I found it 4 or 5 women after that also immediately said, I'm willing to help with the chapatis, I'm willing to do this. So a new community was formed. But yes, the phobia is very huge. And it's not just among people who don't have information, it is among highly educated professionals also, where they don't see, where they lose their common sense and just start listening to the University of WhatsApp. So in the middle of all this is also the nurse who's doing multitasking. She's looking after multiple patients. She's getting instructions from the doctor, and in the meantime, she has to give an input to the family at least once a day, perhaps through a tablet on WhatsApp or Zoom or whatever. And she's being pulled in multiple directions, and she breaks down and she says, nobody is happy with me. The doctor is getting irritated. The family is angry when I go to tell them that this is Ramesh's condition now. The family is snapping at me. The doctor is snapping at me. Why? What am I doing here? Why in heaven's name am made to go through this? Besides which, what other concerns do you think the nurse and the other healthcare professionals would feel in this scenario? So kindly put your thoughts in the chat box.
So earlier, Marianne and Adelina had instances of people who had been in their colleagues that they knew who were affected by the stigma of being a healthcare professional. So, and it's something that resonates through other countries also. We know of this happening in other parts of the world as well. So that is there. Then going on to what you asked specifically about the nurse.
Yes.
I think we'll have to give them a little time to answer. We might go on.
Okay, I will just show them one example of the stigma. The corona lift. Others are not allowed in this hospital. Something like this also happened here. And they said, oh my God, this flat, they have corona patients, and nobody wants to step out of their house, and nobody wants to get into the lift, and they're using toothpicks to press the button. And I've seen things coming up, people filling hand sanitizer in a pen with a cap, and they use that to press the button of the lift and then close the cap and put it back in their pocket because they don't want to touch anything around them. So, and Dr. Chitra, when I heard her presenting this, she also said she's a psychiatrist, and she was coming back from her work, and she is nowhere involved in COVID-19 patients. But she said that when she enters, she reaches home, she enters, people give her a big smile and greet her, but they don't get into the lift with her. They let her go first, and they wait and go later. So this is an experience which a friend and a colleague of mine has also gone through. Again, this is in Kerala, which is supposed to be a state with the highest educated people. So yes, there are multiple issues. Anything new that came up?
No, again, that issue about people who had problems and the healthcare workers who were stigmatized, that issue is still resonating in the group.
Yes.
Because
please feel free to either put it down in the chat or keep it in your mind. We'll have 10 minutes at the end where you can share your story.
Yeah.
We'll allow you to unmute yourself and share what you're going through. So, like I had said, that distress is a huge spectrum, something that we go through on a daily basis, and certain things which are very complex. And I myself learned about these terminologies a couple of years back. So, what is moral distress, compassion fatigue, or burnout? Anyone has heard this? You can just type in yes or no,
or even in the
in the chat
reactions,
box.
or in the reactions, if you kind of you can do a thumbs up or
Yes, and if you have heard this, what do you understand out of this?
Okay, no, we are still.
People are coming up. No, it's okay.
Yeah.
We have time.
Yeah, so they have, yeah, people have heard of compassion fatigue.
Okay, great.
Yeah.
Okay.
At some point have felt it too. Adelina has actually felt it.
Okay. Can she describe what it is, or maybe at the end, if you can explain to us how it felt to you? Because I've felt this too, compassion fatigue.
Marianne said losing some reason to help. Numb.
Yeah.
From everything that is happening.
Yes. So these are very complex things which I had, as a palliative care physician, for the last 18 years, had not heard about it or read in depth about this. So there is this term moral distress. We came into this profession to help people, to help save lives, or to keep patients comfortable. But those are our values. But when we are unable to fulfill those values or carry out our duty, the Hippocratic oaths that doctors take, and we are not able to fulfill it, that results in a distress in our mind. What do I do in this situation? I failed that patient. I have one bed and I have 3 patients. I have given the bed to a 45-year-old with no comorbidities, but he doesn't make it. So he dies. The 65-year-old with comorbidity, he ends up dying. So I'm responsible for all these deaths. Did I make a wrong choice? To who should I give this bed? Should it have been first come, first serve? So these are things which can be very distressing, and we normally don't focus on this aspect when we are going for work, that we are going to be faced by challenges like this. And this is something I would like to take you back to the first day session when we are talking about goals of care with Ramesh and his family. That is where we can talk about what would Ramesh want, what would Ramesh's family want, and perhaps if we know what the patient's desire is, then it is easier for us to take those decisions, and our moral distress or ethical dilemma will actually become less. So compassion fatigue is when we look after our patients, we get involved. We are a part of a large society. We are not immune to feeling sad for our patients. I have sat by the bedside of my patients and shed a few tears with the patient's wife. I have not done one single thing to help, but after the patient has passed away and the funeral rites and everything are over, this lady comes with her 2 sons who are doing medical social work, and she introduces them to me and gives me a thank you card, and I don't know why she's thanking me. It was only because I was sitting there and shedding a few tears with her. So we do give a part of ourselves to every person that we take care of. And in this process, we need to realize that we have to refill our petrol tank. We can't run on an empty petrol tank. So we have to look after ourselves so that we can continue to give this affection, the attention that is required without running out of steam, without running out of fuel to do our job well. Then the word burnout, which is normally what pops up first. These are stresses that arise from the work environment. You think that something else should be done, but your boss has a different approach to management. And there is a conflict, but you cannot open your mouth because your boss does not agree. Or you're struggling with your management because you want more space, you want more beds, you want more nursing staff, you want a hike in salary, and that is not happening. And I'm told that, as I keep mentioning it in most of my sessions, I was shocked. There are doctors in Karnataka, resident doctors, who have not had their stipends paid for 16 months, and they're still turning up for work. In Delhi also, NCR, the government doctors and nurses did not get any salary for 3 months. They went on strike, but because this was essential services and the pandemic, they were all asked to come back, and they all did. They all came back because that is why we are in this profession. So burnout is the stress that arises from conflict with your colleague and management. Now, why this is important is because we will all face burnout in some way or the other in our work environment unless we have a good leader. So how does burnout express? It is emotional exhaustion. You're like, why should I be doing this? I don't want to do this. There's no sense of accomplishment. It's purposeless. Everyone is yelling at me. Nobody is happy with my work. It's depersonalization. So Ramesh again becomes that patient with COVID-19. He does not stay Ramesh. So that disconnect begins to happen. And at one point of time, I did not want to go and see any patient, which was also very distressing for me. So, so we need to understand that low personal accomplishment, emotional exhaustion, and depersonalization and mental distancing from the work at hand, doing it very mechanically, these can also be confused with depression, clinical depression. But they both are very different things and have different, different treatment. For clinical depression, you need medication. For burnout, you don't need medication. You need to be aware that you're likely to go into burnout because of the stresses in your, so you should be aware of this. And if you reach that place where you're emotionally exhausted, then you need to take a break to refuel your tank again. So this is something important for all of us to realize. So these are some terms which I want you to take back, at least from this session, that we've always been talking about doctors and nurses as being warriors. They say that I just recently again saw on WhatsApp that the army wears a khaki uniform, but the doctors wear a white uniform. But they are also warriors, and so are we. But so pushing yourself more and more can make you reach a point where then you are no longer helpful to anyone, and you're possibly punishing yourself. So this is something that you need to recognize. And I have seen that sometimes it's the senior nurses who can identify that my junior nurse posted under me is not behaving in her usual happy, normal self that she was. So I need to pay a little attention to her, or I need to go give her a talk or have a conversation with her. So going back to the nurse, whatever I do doesn't help. What about all of you? What kind of distress have you faced in your work environment as doctors, as nurses, as technicians, what boys, what ladies? What have you gone through? What are
Yeah,
you going through at?
yeah, they are. It's still basically. Dr. Nikhil had a bad situation, so people have read that. But yes, I think we can go on. I think.
So yes, one of the concerns is always, what if I take the infection at home? That's also one major concern. So now there is this concept of spiritual distress. Now, this is a little complex area for me to navigate because I am aware of my emotions and what situation gives rise to what. I can name my emotions. As Sir said in the nurse protocol, I can name my emotion, and so I can talk about it with more ease, and I can identify and use those same terms for my patients. Now, Ramesh's family have become our patients. So, but spiritual distress, spirituality per se, may have multiple meanings and concepts related to different people. For majority of people, spirituality comes from religion. For my husband, he's very religious. He does not go to sleep without doing his daily puja. And I'm someone who finds it very difficult to sit for 5 minutes in the puja room. That's not my thing. So within the family also, the spiritual, where we find our spirituality or where we find our meaning in life is different. So for it is very subjective, it is unique. People who don't believe in God can also be deeply spiritual. That's something that Dr. Param always reminds us of. I wonder if he's has joined us today or not. But yes, it is complex. It can have multiple aspects to it. So, and the spiritual distress, again, so we've spoken about moral distress, compassion fatigue, burnout, and spiritual distress. So, how do we identify what is what? Now, the time is very limited for us to go into the depth of all these things. You have these in your ebook, and you can go back and read these and perhaps go on Google Scholar, and not just Google, to get a better idea. And I think Smriti had also pointed out that Oxford also has a tool for spirituality, and it's more like it's not a tick mark kind of a thing, but certain questions, open-ended questions, which actually you can ask your patients, and they will help you build a rapport with the patient. I'm quoting Smriti because I have not gone and looked at that tool for spiritual distress. So that is available on in the Oxford textbook of palliative medicine. I think the fourth edition is really available on internet. The latest edition, fifth one is not, but the fourth one is. So you can go there and pick up that list and use that for yourself and for your patients now. So how do you deal with all this distress, emotional overload that is happening around you? You go inward. There are people There are lots of people that I hear. I don't know, some of the Indians would have heard of Sadhguru, who talks about inner engineering. And there is Sri Ravi Shankar, who talks about art of living. There are ways where people go inside and connect to themselves. These are ways of meditation, different types of meditation. You connect outwards, you connect to your friends and family. I have a group of friends and we meet every Friday at 8 p.m. And I always look forward to meeting them, because connecting to them, even if I don't say a word, interacting with them, just seeing their faces gives me energy to go through the next week. So connecting outwards and supporting people. Many people actually, after I put that thing on the WhatsApp group, sent me replies separately, personally, saying, thank you for bringing some sense onto this platform. So you can make a difference to the society around you and feel fulfilled with that. And we connect upwards to the divine, to the universal power. If you want to give him a name, you can. Him or her, rather, you can connect to the divine. So, as yeah, so we go back to our clinical narrative. Yeah, lockdown got over a long time back. I don't know where the last 7 months have gone in this year. And I and my son is doing his engineering from home through online sessions. And we are both we're wondering, it was just 6th of June. How is it 6th of July now? What did we do? We didn't achieve anything. We didn't go anywhere. Where has the time gone? We have seen that people have, I'm going to go the other sequence. There have been many losses that people have faced. They have lost their relatives, their loved ones. They have lost Ramesh, who was probably the breadwinner of the family. They have lost Ramesh, who they used to go for advice, for support, for when they were in distress. So they lost him in various ways. One of my colleague, he got his son, he sent him to New Zealand and trained him to be a pilot, and he signed up with a contract with Indigo. And now all planes, there is a complete lockdown across the country and within various countries. So this guy is sitting at home without a job, without a salary. So that's another loss. And all these losses can cause some type of grief or sadness within us. And since no one has been left untouched by this pandemic, all of us, even I, who is on leave, sitting at home, I moved recently from where I was originally working to come to the National Capital Region because my elderly parents are there. And I wanted to be there with them when they were healthy and active, and I could, actually spend some quality time with them rather than turning up when they were ill and in the ICU. But I haven't seen them in the last 3 months because I'm in Haryana, Faridabad, which is a part of NCR, but still in a different state. And they are in Delhi, and I am unable to go and see them. And when I go there, I'm still scared. Am I carrying COVID in my clothes? So I go there with an extra set of clothes, go straight to the 3 months back when I did go see them. I went straight away, took a bath before I interacted with any of them and gave them a hug. So yes, all this is going to lead to a lot of trauma for all of us. And most states have started helplines for psychological support because they understand that the impact is going to be huge, and we are going to be left with significant amount of post-traumatic stress disorder. I wondered if you have heard of this a lady doctor who was 49 years old in New York. She was the head of Department of Emergency Medicine. She developed COVID-19, recovered, came back to her job, and 2 weeks later, she was found in her apartment. Uh, she had died because of self-inflicted wounds.
Yeah.
So this was, so I have a very close friend also in New York. So their parents and I keep talking about, and we all worry about the same.
We have 5 minutes left, I think.
Yes, so I'll just quickly go through these. I'm not going through the algorithms, just going to tell you that these the 2 algorithms are available in your ebook. There is one about psychosocial intervention. You identify, the box tells you what to do and in which direction to go. So how do you do reflective listening? What you use open-ended questions. So it has kind of incorporated the communication, the understanding of the distress, and at some places it tells you whether you need to go to use medicines or you need to do something else about them. So this is dealing with distress and or various psychological issues. There is another algorithm which deals with distress, also points out how to identify grief, to rule out depression, assess risk of suicide. So these are very easy to follow, and I think going back and reading them would be of benefit for you. So coming back to how do we support someone who is in distress? Very quickly, a couple of answers. How would you help your colleague?
So there is some suggestion about talking to each other. Then there is Marianne resorts to writing and compiling documents. Adelina offers a listening ear to whoever needs it. Yes, so listening is important.
Yes.
And I think that comes through again and again.
Yes, absolutely. I think that is something very important. Emotional closeness despite social distancing. That can still happen. Like the senior nurse keeping an eye out for the junior, but the junior being able to approach the senior to say that I'm feeling very bad because I lost that gentleman and he was like my grandfather. So I'm feeling very disturbed. So being able to talk to someone, and validation is naming the emotion and telling them that it is common, it is normal to feel these things in this kind of scenario. There are lots of other people who are going through the same thing. We will all go through this together. At an individual level, we can do things which enrich us. Some people write poetry, some go for a walk in the nature. I have a friend whose favorite hobby is taking photographs of birds. Some people focus on the task at hand, problem solving. That's my husband's way of dealing with issues. So how do we avoid burnout and self-care? Working as a team, recognizing that we are a team. And if you're not a healthy team, we cannot do our job effectively. Enabling and building emotional and social connectedness, which we've already expressed, and having a work-life balance. So taking time out for yourself, that is very important so that you don't reach the stage of burnout, because recovering from burnout is tougher. Identifying or taking time out for yourself is not being selfish, and I'm saying this specifically for the women in the group, because we cannot detach ourselves from our home responsibilities, our children, and our work, and we want to be counted as equal to our male professionals. So if you're taking time out to be away from your family, from your kids, from cooking, It's not being selfish, it's taking care of yourself so that you can perform better for a longer period of time. So we end with a summary that we have learned some complex terminologies, and what we need to do is keep talking to each other, taking care of ourselves, taking care of Ramesh's family, who are also our patients now, because as the definition of palliative care goes, we support the patient and their family through the process of their illness. So they are also our responsibility. So handling loss, and I think yesterday Dr. Roop must have covered grief and bereavement. So kindly go back to your algorithms and ebook. They're quite updated. This is the third version that is available. So I'm going to now stop sharing my screen, and I would like you to see a video, which kind of, I think, for Dr. Roop and for me, summarized what palliative care means and what our role as doctors is. Arun, are you on mic?
Yes, ma'am. Yes, ma'am.
Yeah. So
and we can run the
yes,
the survey also.
video.
Can we do both together, Arun?
I will try, sir. Just in
Yeah.
Sir, first we will share the video. After
Okay.
we can start.
Yeah, please go ahead with the video.
Yeah.
Hunter Adams, you've been accused of practicing medicine without a license. It's a very grave charge, son. Are you aware that it's unlawful to practice medicine without a medical license?
Yes, sir, I am.
Are you aware that running a medical clinic without the proper licensing can place both you and the public in a great deal of danger?
Is a home a clinic, sir?
If you are admitting patients and treating them, physical location is irrelevant.
Sir, will you define treatment for me?
Yes, treatment would be defined as the care of a patient seeking medical attention. Have you been treating patients, Mr. Adams?
Well, sir, I live with several people. They come and go as they please. I offer them whatever help I can.
Mr. Adams, have you or have you not been treating patients at your ranch?
Everyone who comes to the ranch is a patient, yes. And every person who comes to the ranch is also a doctor. Every person who comes to the ranch is in need of some form of physical or mental help. They're patients. But also every person who comes to the ranch is in charge of taking care of someone else. Whether it's cooking for them, cleaning them, or even a simple task as listening. That makes them doctors. I use that term broadly, gentlemen, but is not a doctor someone who helps someone else? When did the term doctor get treated with such reverence as, oh, right this way, Dr. Smith, or, excuse me, Dr. Scholes, what wonderful foot pads, or, pardon me, Dr. Patterson, but your flatulence has no odor. At what point in history did a doctor become more than a trusted and learned friend who visited and treated the ill? Now, you ask me if I've been practicing medicine. Well, if this means opening your door to those in need, those in pain, caring for them, listening to them, applying a cold cloth until a fever breaks, if this is practicing medicine, if this is treating a patient, then I am guilty as charged, sir.
Did you consider the ramifications of your actions? What if one of your patients had died?
What's wrong with death, sir? What are we so mortally afraid of? Why can't we treat death with a certain amount of humanity and dignity and decency and, God forbid, maybe even humor? Death is not the enemy, gentlemen. If we're going to fight a disease, let's fight one of the most terrible diseases of all, indifference. Now I've sat in schools and heard people lecture on transference and professional distance. Transference is inevitable, sir. Every human being has an impact on another. Why don't we want that in a patient-doctor relationship? That's why I've listened to your teachings and I believe they're wrong. A doctor's mission should be not just to prevent death, but also to improve the quality of life. That's why you treat a disease, you win, you lose. You treat a person, I guarantee you'll win, no matter what the outcome. Now here today, this room is full of medical students. Don't let them anesthetize you. Don't let them numb you out to the miracle of life. Always live in awe of the glorious mechanism of the human body. Let that be the focus of your studies and not a quest for grades, which will give you no idea what kind of doctor you will become.
Mr. Adams, please turn and
Don't
press
wait
the
till you're
ball.
on the ward to get your humanity back. Start your interviewing skills now. Start talking to strangers. Talk to your friends. Talk to wrong numbers. Talk to everyone.
Mr. Adams.
And cultivate friendships with those amazing people standing in the back of the room. Nurses that can teach you. They've been with people every day. They wade through blood and shit. They have a wealth of knowledge to share with you. And so do the professionals you respect. The ones who are not dead from the heart up. Share their compassion. Let that be contagious.
Mr. Adams, I demand that you turn and address the board.
Sir, I want to be a doctor with all my heart. I wanted to become a doctor so I could serve others. And because of that, I've lost everything. But I've also gained everything. I've shared the lives of patients and staff members at the hospital. I've laughed with them. I've cried with them. This is what I want to do with my life. And as God is my witness, no matter what your decision today, sir, I will still become the best damn doctor the world has ever seen. Now, you have the ability to prevent me from graduating. You can keep me from getting the title and the white coat. But you can't control my spirit, gentlemen. You can't keep me from learning. You can't keep me from studying. So you have a choice. You could have me as a professional colleague, passionate, or you can have me as an outspoken outsider, still adamant. Either way, I'll probably still be viewed as a thorn. But I promise you one thing. I am a thorn that will not go away.
We will adjourn briefly. Hunter Adams. We find your methods less than appealing. Your appearance and your demeanor do not reflect what we believe is necessary to earn a patient's trust and respect. You openly accuse us of adhering to time-honored practices that for years have been the backbone of the entire medical institution. However, we find no fault in your attempts to improve the quality of life around you. We find no fault in your desire to expand upon existing medical practices and theories. We applaud your love of the patient. Your grades are among the highest in your class, and therefore we find no merit in the decision to block your graduation from medical school. Now, along with your crass and disdainful behavior, you carry with you a flame, which one could only hope would spread through the medical profession like a brush fire. And, Dean Walcott, in the future, I think matters like this could best be solved if you yourself would practice a little excessive happiness.
Thanks, Charu. So thank you very much. This movie is called Patch Adams, and this is a small clip from that where this gentleman is following different practices, path-breaking practices, and he's been brought in front of the medical board to say that he is not following the set protocols, the rules that we are taught to maintain distance. And so this, I think, resonated with me very deeply, because it is a message that palliative care tries to give. If you treat a disease, you may win or lose. If you treat a patient, you will always win. So we have to look at all the aspects of the patient. And remember, there are nurses are our allies. They are our strength. They are our backbone. And learn a lot from them. So thank you so much. Smriti, are you around?
Yeah, I'm here. Thank you.
So I just wanted to thank Dr. Roop for backing me so well. Thank you, sir. And over to you, Smriti.
Thank you. Roop, any closing comments? So that brings us to the end of our 5-day program. I'd like to thank everybody who has participated. I can see that the attendance has remained quite consistent from day 1 to day 5, which is both a testament to your commitment to enhance your practice, as well as a testament to all our faculty who do a fantastic job of keeping everybody engaged. I hope that in these trying times you found something of relevance and something of value in the sessions that we have all put together. And to us, putting this program together was really our way of presenting, well, it was our humanitarian response to a crisis. And now that you have been a part of it, we're all part of the same community. So you're welcome to come and join us again if you feel like any of the sessions had any particular impact on you, or the sessions that you'd like to come back for. And I'd like to extend my deepest thanks to the entire PalliCovid faculty, the PalliCovid Kerala Task Force, who put together the ebook and the resource toolkit, all the faculty who've come on board from all over the world, and incoming faculty, also new faculty who are coming in every week to help us keep this program sustainable. So thank you very much. And do fill out the post-evaluation form. It's not a test of what you've learned. It's an evaluation of how far we've come in the program and what we can do to improve ourselves going forward. So thank you. Stay connected. You have access to the Pallium India webpage. You have access to all the Pallium India team, and through us to the larger faculty pool. If you're interested in learning more about palliative care, there's a series of training programs that are going on across the country and also in the Southeast Asian region. We can connect you with our colleagues there as well. And we're constantly running programs on some of the more in-depth topics around palliative care. So don't hesitate to sign up. We'll be very happy to see you there. And thank you again. Stay safe and be well. Thank you.
Thank you, Smriti. Thank you, Charu. Thank you, everybody, for being there. Bye.